Hello, everyone, to MedEd Debates. Sorry about the English for this episode, but you will have subtitles. So, hope you're able to enjoy the conversation. So, in today's episode, we have Dr. Abdulkarim Ismail, who is a registrar, a second-year registrar, a medical doctor in the UK. He is actually a jack of all trades. He studied medical engineering. He studied history and philosophy at the London School of Economics. And he's also a DPhil student at Oxford University. He was in education. He was actually my supervisor, and I'm very honored to have him here. Today, he will discuss about his experience, will walk us through about his experience as a medical student, and we'll take it from there. So thank you very much, Dr. Abdul Karim, for uh, hopping in here.
Thank you very much for having me. Looking forward to our discussion.
Thank you very much. So let's kick it right from the start. May I ask you, what made you choose medicine?
This is a good question. I think I do ask myself the same question quite frequently, maybe more so in the past few months. When I was at college, I did find significant interest in many subjects. I was a bit torn between what to do at university. I think a lot of it came down to me wanting to learn as much as possible, and medicine was a very broad subject where I didn't necessarily have to focus on one organ system at a time. Um, I could sort of explore many different complex organ systems. There's a element of physics and mathematics in it. There's elements of chemistry, pharmacology, and of course genetics, biology is very heavy in the degree. And so I think that was one of the driving factors between medicine and equivalent subjects. I was also considering sort of any type of literature, engineering type degrees, even some creative degrees as well. But I thought medicine allows me to do to explore a large variety of topics. And also there's an element of the professional development that it will allow me to develop, communicating, for example, with patients, colleagues, seniors. It's a very dynamic role, being a doctor. And I think that was also something that I was looking towards.
Thank you very much for your answer. So, you studied at Queen's Mary University of London. Is that correct?
That's right, yeah. So the medical school, it's called Barts and the London School of Medicine and Dentistry, and it's part of the Queen Mary University of London.
Yeah. Could you talk us a little bit about the curriculum? How long is it and the structure of it a little bit in like maybe 2 minutes?
Of course, yeah. So well, one of the reasons why I applied to Queen Mary was that among many claims, one is that it has one of the oldest traceable records of medical teaching. So they have medical school teaching going back all the way to 1123. And there's a strong element of the history at the university that they're quite proud of, that they like students to be able to explore as well. And I guess that will lead on to some of the other things that I will talk about with regards to the curriculum. Um, the curriculum is a 5-year degree. It's a bachelor in medicine and bachelor of surgery combined. And generally, the structure is similar to most medical schools, where the first and second year are preclinical, mainly biological sciences, and then the third, fourth, and fifth year are clinical years, and they're mainly based in hospitals, moving away from lecture theatres and labs. One of the things that is quite core to their curriculum is that the idea of a spiral curriculum. I think that extends in many other locations where they either take a organ and system based approach to organizing the curriculum, where you explore the biology, the physiology related to certain organ systems, and then you build upon that every year, but with more clinical relevance. The other thing that they do that is that I thought works really well is that they have quite early clinical exposure. So you have placements even in first and second year in mainly in primary care, so in general practice or community-based locations, just to develop that familiarity with patients and with colleagues, developing communities of practice. And then when you go into third year, which is your first year of hospital rotations, then you already have some familiarity with the clinical environment. In the first and second year, in addition to lectures, lab-based work, dissection, they also have sorry, classroom-based seminars that are they call it problem-based learning, and sort of going through different clinical scenarios from with a clinical reasoning structure and doing it in a very in a group work dynamic rather than didactic teaching. Then moving on to the clinical years, hospital-based placements in various hospitals. So it could be sort of secondary, even tertiary care, different departments. And the aim here is that there's the lecture week where you go through the main content and revise the main content, but it's to practice and explore clinical scenarios. So it's less of an organ system based structure and more of a sort of more common and serious clinical scenarios. That's the type of structure that the clinical years would implement, and so it's just becoming familiar with things on a case by case basis. So basic examples, if you're in a cardiology rotation, then you would, for example, become familiar with heart failure as a condition, and then how prevalent it is, its management, etc. Do the same thing with hypertension, or do a similar thing with any of the sort of acute coronary syndromes. And that sort of case-based approach is examined in a portfolio where you have to be able to do certain examinations, demonstrate certain clinical skills, demonstrate certain history taking and communication related activities, and those are all signed off by senior clinicians. And so there is a lot of self-directed learning here. And then sort of after the various clinical rotations, then there's examinations that take place throughout, some of them practical, some of them written, and sort of throughout the 5 years, the other core component of the curriculum is that they have something called student selected components. So roughly 2 or 3 times during each year, more often than not 2 times in the year, there's a list of student selected components, but there's also the option to create your own sort of student selected component where you can explore an area of medicine that you're interested in, and seek a clinical placement or academic activity that is related to that. So I
Yeah.
think, yeah, that's a brief overview.
Thank you very much. That's a very complicated system that I think will take a lot to adapt to. What kind of challenges did you like? What kind of challenges did you face, going into the spiral of, activities at medical school? I think you come from very, much less complicated, study focused, academic, narrowed, whereas here it's like a lot of activities happening all at once. Uh, could you tell me what are the personal challenges that you faced, being a medical
Absolutely.
student here?
Yeah. So I think one of the main challenges I found was sort of developing your own skills to sort of self-direct your learning and to do sort of self-regulated learning, because as you say, there are so many components, and each of them has their own advantages and things that the curriculum is aiming to impart to the students. And I do think that there is a good structure of support to help you through developing sort of an adult learning approach, that's sort of quite autonomous. But I think that that lack of structure and the variety available could what was definitely a challenge in the sense of there's a significant cognitive load that comes from organizing and managing your own learning activities. A lot of thought that goes into that as well, which of course reflecting on your future career aspirations and things that you enjoy can be helpful. But also a lot to do, a lot to take in, a lot of as I was talking about the portfolio, there's a lot of checklists, a lot of deadlines, and I do think that that was a challenge, and it was something that you need to keep on top of from very early on, and it could potentially be quite easy for a student to get lost and to fall back on a lot of those things.
Yeah. And in terms of assessment, how hard did they go on you with the assessment? Is it like very intense assessment, a practical one in the first, second year, especially like being a newbie at the medical school?
I don't think they were too intense on the assessment. I do actually think that the assessment was quite a good reflection of what was sort of expected to know at each level. I'll give you an example. So we had OSCEs, so that's the clinical
At what year?
examination in our first year. From the
Oh,
very first year,
wow.
we had OSCEs. However, the mark scheme was very I want to say lenient, but I would say also appropriate for the level of a first year medical student because just having familiarity with the OSCE environment was so helpful just continuing going on because yes, the expectation was quite low in the sense of yes, we had to do some examination skills, but I want to say that that it wasn't so stressful in the sense of you have to get everything exactly perfect to pass the station, but the fact that we had the OSCE helped with the next with all the years going forward, and I think developing the confidence and the skills, but in a safe environment where you feel like maybe you're not being tested so intensely, but you're being tested nonetheless. So you do have to do the preparation beforehand, and we had similar things with the written assessments. So we had assessments throughout the year where they were formative assessments, but just having that to keep on top of things so that you know that you're working at a reasonable rate to get some feedback as well, and then it's not so much of an intense period when you come to the final year exams.
So the formative assessments, what percentage were they in comparison to the summative assessment?
So we had three formative assessments throughout the year. They didn't contribute anything to the final grade. Um, if you are identified as performing less than the pass mark, then that would be something that you'd be offered assistance and support by your tutor
Yeah.
regarding. But they didn't contribute at all to the final
Do you
grade.
think they are necessary? Don't you think they could be a waste of resource?
I hmm, I do see the point of them being reasonably unnecessary. I think it depends on the module. I think it would be very case specific because I did find that there were some of these formative assessments where maybe the module didn't have so much content, and so it wasn't such a productive activity to have a full on assessment about it. But in terms of the more content heavy modules, I do think it was a useful it was definitely useful to motivate myself, to motivate my colleagues to revise and do well, and that means that you then do less at the end of the year because you already have some level of familiarity. And also I think it's helpful to get some to do some self evaluation, to see if your revision methods, if your academic strategies are working appropriately as you'd expect for a exam that doesn't have any, I guess, long-term consequences compared to do learning all of that with the real deal at the end of the year.
Uh, I see. Uh, but couldn't you do that with the summative assessment? Couldn't you just like walk off the summative assessment and like maybe reflect a little bit on what you did right, what you did wrong? So I'm kind of lost a little bit on, why should the university invest on formative assessment since if the students can think of their answers and how they did on the summative assessment themselves.
Absolutely, I think they could. I just the fact that the summative assessments have consequences. So if you learn your or you refine your strategy and your technique with the formative assessments, then you don't necessarily have negative consequences from negative feedback with the summative assessment. So I definitely do think that they did add a level of stress because of course it's still an assessment. But I do think that the self-regulation strategies that as a student can develop from a formative assessment is definitely beneficial and transferable to a summative assessment without any of the negative consequences. And I guess it comes back to the aim of the course is to teach students and to enable them to learn. And that's not just the content and the curriculum, but it's also enabling them to learn strategies and approaches to complex tasks. And I do think that formative assessments are a means by which students can achieve that.
Yeah. So what kind of form do they usually take? Are they only written assessments or can they be practical assessments where, just like the OSCE you've mentioned, but like mini CEX, for example?
Yeah, yeah. So there were a combination. So in the first and second year, so the preclinical years, it was primarily written assessment. So there was a combination of multiple choice questions and just normal writing, extended, not just writing questions. Um, so that was primarily written. But when it came to the clinical years, we also had like simulated patient sessions or mock OSCEs. So these were opportunities where you could set up a student with a patient in an examination type context and then observe and give feedback on that. So I guess similar to a mini KEX, which is what we sort of had in postgraduate training. But again, that with the clinical formative assessments, it's less sort of reproducible between different placements. So some placements had really good simulated formative assessments, whereas others maybe didn't have the resources or the staffing to provide that. So there is that additional variability that does come from clinical placements. But I do think that having it present overall and having the portfolio where you're expected to get certain things signed off does provide a minimum level of competency for the students.
So you said portfolio. I might be a little bit familiar with it, but could you explain it just a little? Two more questions to go. So looking
Yeah.
back at your medical school, so I've got some interaction with the NHS system, and I think
Mhm.
it's very busy, and it's like you have different kind of mechanisms to like find a patient, treat a patient, restore their record, and sometimes there could be, the patient could go through some repetition, and it's a whole different thing. Did the medical school prepare you anything to handle this system? You talked that, it didn't very much. And how would, let's say, integrate this more into the medical school system? And what other things you would like to add or change in the medical school to make it better experience for everyone?
Mm. That's a very good question. So I think so. The medical school did as well, I think, as could be reasonably expected to give us familiarity with the various systems. As you say, they I don't think you can prepare any student, especially because it varies so much across the country, for all the particular systems that are being used. But I do think with the general principles of knowing how to access paper notes, for example, and where different things will be, and how to appropriately document things in paper notes. Is something that we learned. Also, the GP system. So most GPs in the country use a system called System One, and so there are a few others, but slowly everything's moving towards becoming universal. And we did experience familiarity with that as well in our general practice rotations. And so I do think that there was some familiarity. I don't know what could be changed to improve it? I think that's a good question, because while they did give us the general principles, I don't think they can prepare us for all the different variation that is available. But moving to, I guess, the more general question that you asked about how I would adapt or amend the medical school curriculum, I think there's a few things that I think were maybe overlooked, or maybe not overlooked, but as I said, there was a lot of student selected components. And so if someone was interested, maybe they could seek opportunities to learn these areas. But it wasn't sort of universally available. And one of them, I think, was sort of humanities, and humanities philosophy, and the social sciences element to medicine, because I think having sort of done a degree that is related to the social sciences, and the humanities, and of course doing my PhD in education, there are elements of motivation, engagement, attention, psychological theories about resilience as well, that I think would be very helpful to integrate into the medical school curriculum, because they not only relate to how someone can regulate themselves, and their own practice, and help them reflect on their own psychological state and approach to things, but also with regards to patients. So as a GP, as a GP registrar, the majority of my day is talking to patients. For the first 10-15 minutes, the last 10-15 minutes is talking. And I want to say that one of the superpowers of a GP is therapeutic communication. Of course, we can prescribe, we can help patients navigate the system and refer to the appropriate specialties, and be their advocate. But I think being able to talk to someone, identify what their motivators are, what their perspectives are, their concerns, ideas, concerns, and expectations, and reconcile that with your own, understanding it in various philosophical and ethical constructs, maximizing autonomy, enabling the patient to make their own decisions, their own informed decisions. These are all elements from the social sciences, the humanities, that I think have a very significant bearing on being a good and functioning clinical practitioner. And I think being aware, I know that we practiced a lot of these techniques, we practice a lot of communication, but being aware of the evidence base behind it, the theoretical frameworks underlying some of these things, self-determination theory, I think is a very important one that I use on a daily basis, with my patients, and that I think has very beneficial outcomes in terms of health promotion. So helping them to make the right decisions for them, and helping them make autonomous decisions and not someone dictating to them what they should be doing. And so I think that's something I would necessarily change, is having more theoretical frameworks underlying some of the communication skills that we learn. One thing, again, I think, I know I'm giving a lot of points here, but reflection was another thing that we were taught to do. And there is a way of doing structured reflection that I think is very beneficial, but often, especially earlier on, I wasn't sort of given much guidance regarding how to reflect in a constructive way, and it felt more like a burden or a frustration, or a tick box exercise that, oh no, I need to reflect again, and I didn't really see the benefit of it. And I think that it's something that's difficult to get right, but I think it's something that is very important, especially that I've come to appreciate more now than I did.
This is more on the personal side of things. Uh,
Yeah,
so you studied LLSE, you studied Masters in History, Philosophy of Science, something like this, I believe.
yeah, yeah.
Uh,
Philosophy of science.
what what made you pursue this degree? And like you were studying medicine. What made you pursue this degree in specific?
That's yeah, I'm thinking. So, I've always wanted to go into academic medicine. I think from a young age, my ideal job was a professor of medicine. And of course, that comes with the necessary, well, the necessity to pursue a medical degree, to practice clinical medicine. And I think it's something I didn't want to sort of give up on at any point, was the ability to continue developing my clinical knowledge. So I wanted to always be a practicing clinician, and I think that's where general practice helps, because it's such a broad area of medicine. You can sort of keep up to date on many organ systems, and there's a lot of diversity of patients that you can see. So that's really something I wanted to do. But then the academic side was also something that I needed to facilitate. There are pathways in the UK where you can sort of integrate the two of them. But I kind of wanted my clinical work to be very separate from my academic work. I didn't want them to relate to each other and affect each other, and sort of be conditioned on each other even. And so that meant sort of taking the traditional route of BSc, MSc, PhD. And so that was always something that I wanted to do, whether or not I did it while I was at medical school or while or afterwards was the question. So in the UK, we have another system called intercalated degree. So after your second year of medicine, you can apply to do an intercalated degree. So it basically means that you do a BSc in equivalent biological sciences or subject in 1 year. So you take a year out and you do that. So I did mine in bioengineering because I was very much interested in physics, electronics, programming, and that's something I hadn't really done much of, and I did enjoy it when I was at college, and so I did that. And then after I did that, I sort of was thinking more about the philosophical perspectives of science, which was very reductionist. So identifying ideas in as reducible terms as possible. Determining knowledge as something that is reproducible, that is, of course, the traditional definition of justified true belief, but also something that's probabilistic and contingent. So it's very much dependent on particular perspectives. And so exploring all of those things in a bit more detail led me to the philosophy of science degree, which was very much about the principles of science, how science operates, the assumptions that science operates under, how science relates to other subjects such as the humanities or the historical method. And so it was sort of a stepping stone between my own sort of general understanding of the universe and my place in it, and trying to explore that in a very structured and methodical way. And so that was the degree was perfect for that. It did make me think a lot. I did find it harder than everything else that I'd done before because a lot of the concepts are very abstract. A lot of them are not testable. A lot of them are, and so it helps you to sort of identify what is valid and meaningful discussion from, I guess, just conjecture. And so that was a useful part of that, and that did lead on to my PhD, which is of course in education. And there's a lot of philosophy of educational research, medical education research, as well as sort of exploring our underlying assumptions to things. And I did think that the knowledge that I gained from that degree, which I would highly recommend to anyone really, in any subject, um, to explore with philosophy of science. It's kind of how we know anything really, with any again meaningful utility. And so yes, so it was sort of very transferable, and I did find I was using a lot of the principles in my PhD, which of course is trying to understand the psychological states, but in a way that we can measure with physical devices. I'm trying to use EEG, so brainwave activity, as a measure of psychological states that are correlated with motivation. So things like cognitive load, attention, and the interpretative steps going from data points to an understanding of someone's psychology is something that can be done terribly. And so that's something that I wanted to avoid. And so those principles, I think, are very translatable in many domains of academia and also in medicine, as I think I've touched on in a previous answer.
Yeah. So a lot of the work that you've said do correlate with some of the social science principles, but a lot of it in practice, you do a lot of your education, a lot of your, research falls into like hard sciences. And this is where the clash of paradigms come, as a medical doctor yourself. And like a lot of doctors here do find it difficult to, comprehend. It's in the UK, it's less now, but in here in Syria, they do not like yet comprehend social sciences as a science itself. It's not, measurable. It's not, statistics or, real things like that. So, how did you come to resolve this dilemma, I would say?
Yeah,
I think I passed through this stage myself as like a dentist, then do studying social sciences and medical education, and you yourself
yeah,
who's studying engineering, medical sciences, and then going to social sciences, and especially in the Department of Education at Oxford, where it's less hard sciences and it's more social sciences, humanities, philosophies. Prove me wrong, prove me right.
yeah,
Uh, how did you solve it? How did you come to peace with all
yeah,
these conflicting
yeah.
arguments about what is real?
Yeah, absolutely. I would like to sort of preface my answer with the fact that I'm very open to having my mind changed. So I probably will say some perspectives that I have, but maybe I won't necessarily have in the future. So yeah, feel free to try and convince me otherwise. Yeah, yourself or anyone else that would be listening. Um, it's a funny situation because, as you described, when I'm within the social sciences realm, so Department of Education and Social Sciences Division, as the medic, and given the nature of my research, I'm very much seen as the empiricist or the I'd say hard scientist. Um, Whereas when I'm in other circles, so bioengineering, for example, when I'm attending conferences or doing similar work in genetics or things like that, then as the medic, I'm seen as the social scientist or the humanities type person because what they're doing is for want of a better term, even purer science than medicine. And so it's an interesting dynamic to have in this interdisciplinary context because I guess it is observer relevant. Observer, the perspective is observer dependent. But I think the way that I've sort of approached it is that are they necessarily so different, the social sciences and the humanities, as the social sciences and empirical sciences? I know that we sort of generally taught that, yes, we have the empirical sciences, social sciences, applied sciences, humanities, and they're all quite different to each other in the way that they operate. I do agree with that to an extent, that maybe the empirical sciences like to define things in very precise terms. The core structure, for example, the brain. So it looks at the brain in terms of the nerve cells, and then it goes on to structures of that, combine them hierarchically, and then they perform a particular function. Whereas with the social sciences, a lot of what we do is because we don't understand the way that the human brain works so precisely, we take we look at the phenomena that we observe and we try to make relations from like a top down approach rather than a bottom up approach. And so I think that that can be a challenge. But the aim of both is the same, to produce knowledge that or experimentation or experimental manipulation that is reproducible and repeatable. And so if we work with those basic scientific principles, and we work from a perspective of statistics, and I think that is something that has really helped. And I think it's interesting because even in the social sciences, there's such a heavy emphasis on learning statistics, and I think that statistics, as it is a science of uncertainty, it's propagating errors, and I would argue that it's also the most foundational science because of course, as agents, as human beings, we have the ability to perceive light. We have the ability to perceive pressure as either touch or sound, and we have the ability to detect chemicals as in our taste or smell. And that's sort of the extent by which our interaction with the universe goes. And even those measurements have precision, right? So the precision of the light detection of the human retina is about 2 photons of light, and so we can't detect 1 photon of light on our on in the macula. So that's the limit of detection, and of course those individual limits then propagate. And so being able to propagate uncertainty is what the purpose of statistics is, and then by extension what the purpose of science is. I think the difference between social sciences and empirical science is just the level of precision that we're happy with. So in theoretical physics, for example, you might have a very high level of precision that you want to reach above 95% confidence. of the true value being within a particular range. But in the social sciences, we might be comfortable with a smaller level of precision. And but that's okay. That's just giving us the ability to interpret. So we're saying that with this degree of confidence that the true value lies within this range, and that's all we're saying. We're not giving an absolute um, uh, assertion as to how things are or what reality is. And I think that perhaps these questions might not be able to be answered in any comprehensive way, but that's what statistics is there for, that it gives us a framework to describe phenomena in a repeatable and reproducible manner, but managing uncertainty. And I think that's how I've sort of come to view things. Accepting my uncertainty, accepting my assumptions, but saying that there is a structure and framework by which all of these sciences operate, and that's why they're sciences.
Yeah. You're like oozing a lot of scientist vibes right now.
No, I know. um, I have worked. I've done some work in the public health department, and I have had a lot of criticism about perhaps being too scientific in my approach. As to how I've reflected on that is a topic for my educational supervisors, but it's an ongoing thought process. Yeah, definitely.
I think you can choose the area or your playing field,
Mhm.
and especially you chose your default subject, which is very medical and biological thing that you can bring it down into numbers and statistics, especially with the way that you did it with the ECG and like electrical
Yeah,
signals and stuff. So you could definitely do measure it down to statistics. But I'd rather see statistics as a tool. It's sometimes the measurements that we make that we reduce to statistics is that really depends on how we measure things, is how we decide to measure things in social sciences and what we count, what we, reduce to numbers. That's what really very important. Not, the statistics itself is very important, but do a lot of social scientists do neglect the fact that the way that you are reducing meaning and emotions, like for example happy from 1 to 5 or like sad from 1 to 5, is very very inaccurate, and you need to
yeah,
understand the meaning of each time you reduce it, like you give that a number, so that your interpretations when you boil it down to statistics and make a, let's say, a finding, let's say, it's really dependent on how you reduced it in the first place. And
yeah,
that's usually that is usually goes overlooked. And that's why a lot of social that's I think that's why a lot of social scientists do have a problem with statistics, that it's
yeah,
you can't reduce meaning of life into numbers.
yeah, yeah.
And I definitely agree, but
Mhm.
I do see the utility of statistics in it.
Yeah, yeah. I agree with you. I think that that's very much the role of qualitative research. And I think it's extremely important in terms of justifying how we go from a complex phenomenon to numbers, as you say. And it's done very badly many times. And of course, in that journey as well, you lose pieces of information. And I think that's why it's important to be aware of both. And define, when you are using statistics, define things in as strict and accurate way as possible, but also being aware of your own biases in terms of the experimental method. And I think that that does sort of lead on to just a general appreciation of good quality experimental design versus the opposite.
Yeah. It's very fun. It's very fun.
Yeah,
And there are a lot of controversies in it. So
yeah,
that's what
yeah,
makes it very, makes
yeah,
everybody's on their toes all the time and ready to
yeah,
defend their, what they
yeah,
believe science is, what they believe research is, what's the right
yeah,
way is.
yeah,
So yeah, it's may the conversation goes on and on, as long
yeah.
as we are enjoying it.
Absolutely. See, I love that about social sciences, right? Because of course in engineering and biological sciences, you design an experiment, and it's quite easy to see what you're measuring, the outcome that you're measuring, and to make those manipulations. But in the social sciences, when it's done really well, when a researcher has converted a complex phenomenon into something that they can experiment on and then get some results, I think that's way more impressive than doing something similar in a biological system or in a chemical system where it's easy to manipulate the variables and control variables. Whereas in the social sciences, it's very difficult to do so.
And your research is right on that, because you're validating a tool that measures motivation using ECG, which is quite fascinating. And you're, doing a validity study or everything. And I've, attended your seminar. It's
Yeah,
really, really fascinating. And I do hope to see more of this
yeah,
because, uh, beyond the paradigm wars, I do see a connection. I do see a connection. The human element, the interpretation of things, we're usually sometimes a little bit wrong on that end, but that's
mhm,
not to make, to wrong statistics or to wrong a certain field of science,
yeah,
uh, just because we don't agree with it. So
absolutely.
please, please, I'm very interested to see your final piece of work.
Yeah, yeah, me
Thank
too.
you so much. Thank you so very much for, attending today's episode. And I think the audience will make great use of a lot of the things that you said. Uh, so thank you very much, Dr. Abdulkarim.